Well, I think it's 12 o'clock, so we will get started. Welcome everyone to this webinar. It's a pleasure to be here with this esteemed panel and all of you who are joining us live for the webinar titled Thriving and Staying Strong Through Menopause and Beyond. And as Karen Adams, one of our guests, said in an earlier podcast, menopause is having a moment. And I know that for many of us, we've had our menopause moment, but I think she means in the greater context of society. And this was confirmed when I was in the grocery store line the other day, and I saw that Oprah has an entire issue in her magazine dedicated to menopause. So it's hit mainstream, and it's really great that we are all talking about these issues now that affect more than half of the population. I will do intros in a moment, but first just a little business about the webinar. So your mics and cameras are off, and we have disabled the chat, but we really want to hear your questions. And so please put them in the Q&A button in the webinar, and we'll be looking through those and we'll feed them to our panelists as we go along. We'll be talking for about 40 to 45 minutes amongst ourselves, and then we have 30 minutes, because this is an hour and 15-minute webinar, where we can answer all of your questions. So, our goal is to get the questions from you and share with the information that you really want to hear about. The session is being recorded, and so all of you will get a copy of the recording, and even if people didn't show up, they will also have access to the recording in a day or two. So, some intros. I'm Ann Friedlander. I'm the Assistant Director of Stanford Lifestyle Medicine and Adjunct Faculty in Human Biology and an exercise physiologist. And if you want more information about lifestyle medicine, Stanford Lifestyle Medicine, you can go to our website. There's a lot of information there, but basically we are trying to bring information to all of you that's actionable, science-based, and informative. And we also have a lot of educational programs where we are training people from high school all the way through their professional careers on lifestyle medicine. And we have Rachele Pojednic joining us here. She's also adjunct faculty in HumBio, and she is the Director of Education and Lifestyle Medicine. And she's knowledgeable enough that she could probably be one of the panelists, but her main role here is actually to get your questions, collect them, and give them to Karen and Stacy. Okay, so our panelists today, you may have read their bios on the registration page, but I'll give you just a brief overview so you can put them in context. So we have Stacy Sims, who's joining us from New Zealand. She is an international recognized exercise physiologist, nutrition scientist, author, podcast regular, and fitness company advisor who focuses on optimizing performance for women. She currently holds a senior research associate position with Sprins AUT University, and her most recent book, Next Level, has the subtitle, Your Guide to Kicking Ass, Feeling Great, and Crushing Goals Through Menopause and Beyond. So this should be interesting. And then we have Karen Adams, MD, who is a clinical professor of obstetrics and gynecology at Stanford University, where she is the director of the Menopause and Healthy Aging program, among many other positions. She has focused expertise in menopause management, female sexual dysfunction treatment, and lifestyle medicine. She is an internationally known menopause expert and delivered a popular TEDx talk titled Sleep, Sex, and Menopausal Zest. So I think we are in for a lively time with these two women that's going to be very informative. And thank you both for being here. So this is kind of my new thing. I really like bringing together experts with slightly different perspectives to talk about a topic, because I think it gives us a breadth of information that you can't get with a single person. And there may be some discrepancies or conflicts in the information that we get, but that's what makes science great, is sort of figuring these things out. So I'm very excited about this podcast. So thank you again for being here. So enough of me rambling on. You're here to hear from our guests. So I want to get a little sense of these two fantastic women and what draws them to do what they do. So they're both passionate about helping women. Stacy, why have you directed the majority of your career towards understanding women and helping them perform well and be healthier?
It started as a selfish endeavor as a young athlete, wanting to know more about how to be a better athlete and not finding any female representation in any of the literature. The textbooks were always he or they. There was nothing ever directed towards women. And through different experiments and scientific papers and conferences, there was never that representation. So I started asking why and finding out that there wasn't really that much out there, or things were just generalized to women. And then as I got older, it became less about being selfish as an athlete and more about the greater good for my fellow teammates, coaches, friends. Then working with Marcia Stefanik at SPRC and looking at the older cohort of women who still want to be viable and active and lively when they're in their 70s, 80s, 90s. It just brings this whole thing together where we've been confined into a scientific design that's been designed by the people in the room who are primarily men. And women have always been an afterthought. And I don't like that injustice. I don't like that inequality. And that's the deep-seated drive to keep going, is trying to find the equality and trying to find better information and research that's specific to female physiology.
I just have to say that you're so right. I mean, I'm just surprised you're not pounding the table when you're saying this, right? Because it's the same thing in the medical world, and I love your TED Talk, Women Are Not Small Men. And, the Women's Health Initiative was this big study about hormones. And it took a woman head of the NIH to think, hey, we maybe should study this a little bit. So yeah, I'm already cheering you on for that. I couldn't agree more.
Yeah,
That's why we're sitting here together.
I know. I'm so glad.
Yes.
exactly right. And Stacy, you speak to so many women out there who, feel heard, that you are studying, women's physiology and presenting this information to them in a very inspirational way. So thank you so much for doing that.
Thanks.
And Karen, you as well. You have focused for 30 years on helping women in clinics. And so what drives you? What are you most excited about when people come in, helping them through these transitions through menopause and beyond?
Right. Really, it's because there's just so many of us. There's so many of us. More women will go through menopause than will ever experience pregnancy, right? And women's health, we so often are talking about pregnancy, which is super important, absolutely important. But that's not even as many people as will go through perimenopause and menopause, which, if you have ovaries, it is literally 100%. And I do want to say, as we embark on this webinar, I'm going to try to say menopausal people or patients, but if I say women, I mean people who have ovaries, because that's what triggers menopause. But I recognize that not everybody who has ovaries identifies with that term. But at any rate, 100% of people with ovaries are going to go through this. And when you think that perimenopause can really be manifesting normally in your early 40s, and where lifestyle medicine and longevity medicine is helping us live to be 80, 90, 100, it's not out of the realm of possibility to think that we're going to all live to be 100. This is a huge time in a woman's life. It's almost half of her lifespan, and the decisions that she makes around the time of perimenopause and menopause can make a big difference in what she's doing when she's 80 and 90 and what that quality of life is. I'm not sure I want to live to be 100 if I don't have a good quality of life. And that's really where lifestyle medicine comes in. And, guiding people through this is something that, feels new to me every day. I just love it. And as long as it's fun, I'll keep doing it.
And have you found that the conversation has changed over time, over your time doing this for 30 years, about what women come in for? Like, what are the main symptoms? Well, first of all, define menopause, and then what are the main symptoms or reasons that they come to see you?
Mm-hmm. Right. It has really changed. And, the definition of menopause is no period for 12 months. So you go 12 months, 1 year with no period. And that's the definition of menopause. Now, we only diagnose that in the rear view mirror, right? You don't know when you're having your last period. It's, it's only a year later you go, well, I guess that was it, because no more since. That can be challenging if you've had a hysterectomy, obviously, or something like a Mirena or a Liletta IUD, which suppresses periods. And so then in that situation, we diagnose it with symptoms, not really with blood testing. And we can talk about that a little bit more if people are interested in that. But it's really a clinical diagnosis, it's symptoms. And it really is kind of a mixed bag. Some people come in because of symptoms. 80% of us will get hot flushes and night sweats. And so that drives a lot of people to come into the clinic. But also the awareness has become so much greater that I'm even seeing people in their late 30s coming in saying, I just want to be prepared. So what should I know? How should I be thinking about this? Which is just fantastic. I love that, because there's no such thing as too much information, too much good information.
Yeah. And so what causes these major symptoms that people come in with? So you mentioned hot flashes, night sweats, irregular sleep patterns.
Yeah, right. Yeah, the main symptom is hot flushes. 80% of us get that, but about 70% of us will get mood disorders. There's this thing called perimenopausal mood instability, or PMI, that is more common than PMS, but nobody's ever heard of it, right? We all know what PMS is. We talk about it, we know about it, but PMI is more common and we don't talk about it. So that's something that people often feel. They feel their mood is kind of unpredictable and not so good. Sleep disturbance, joint pain. About 50% of people get joint pain. 50% of people get dry vagina and pain with penetration, with intercourse and putting anything in the vagina. So any of those things can drive people. And then there are less common symptoms, even things like burning mouth and ringing in people's ears. I guess my message to folks is, have a wide index or a high index of suspicion that, there can be sometimes atypical symptoms that drive people to come into the clinic. And then just coming in to get the information is always good, because we're happy to talk about it before you ever experience those things.
And then as a physiologist, I want to jump in because I had this question before of what exactly is causing the symptoms. And right. And people are like, well, I don't understand. And I tried to explain, we have estrogen and progesterone receptors everywhere in the body. And if we talk about what happens at the onset of puberty, we see all of these changes, and then a girl gets her period. We're on the other side, where we're having all of these changes through every system of the body that has been exposed to a cyclical ratio of estrogen progesterone for decades. And all of a sudden we're having a downregulation. So we see it affects the brain. We see fMRI, or the functional MRI of the brain, and we're seeing a massive light up of estrogen receptors, but it's because it's trying to look for the estrogen. And because it's not getting it, it starts to downregulate. So it becomes less sensitive. So we're seeing these changes in the brain volume, neuroplasticity. We're seeing changes in neurotransmitters. So we start seeing all these mood issues. And it goes all the way down from the heart and how the heart responds, because it's a muscle, skeletal muscle, bone, gut microbiome. Everything is affected, and that comes out as symptoms.
Mm-hmm. Oh, that's so beautifully described. And, the research that's coming out about the brain and the estrogen receptors is just amazing, that as women age, not on hormones, their brains light up more and more and more with estrogen receptors. It's like the brain is trying to sop up all the estrogen that it can find, and when women go through menopause at any age, whatever age they are, their total cholesterol goes up, their LDL goes up, their blood pressure goes up, their glycemic control becomes dysregulated. So it really is kind of a time of hormonal chaos that is affecting basically every body system.
Yeah, we'll jump in about hormone therapy in a moment, but since we are Stanford Lifestyle Medicine, I'm very curious about what lifestyle changes people can do to sort of treat or mitigate some of these symptoms. And I'll start with Karen, and then I'll move to Stacy and sort of the exercise realm.
Right, right. So when we think about non-hormonal treatment methods, we're really talking about hot flushes mostly, because that's the biggest group of symptoms that people have, daytime or nighttime. And when you think about non-hormonal treatments, there's sort of two categories. There's the medications that are not hormones, but then there's all the behavioral and lifestyle things. And it's really interesting because I've been doing this for 25 or 30 years. I used to recommend certain things that I don't recommend anymore because the data doesn't really support it any longer. So things like avoiding triggers, we used to say, avoid spicy foods, avoid alcohol, avoid hot temperature foods. And none of those things really have been shown definitively to make much of a difference. Same thing with yoga. I used to recommend yoga, and we can talk about exercise a little bit when Stacy weighs in. But the only ones that really good data exist to support the use is, number one, cognitive behavior therapy. Cognitive behavior therapy is very effective in decreasing the bother and the distress that is associated with hot flushing. Doesn't necessarily really change the frequency of them, but it really helps people cope with them. So that's a really wonderful resource to access if you have access to cognitive behavior therapy. The other thing is clinical hypnosis, which is a little harder to access and a little bit more murky as far as why that actually really works, but it does. And then there's a thing called a stellate ganglion block, which is very invasive, and it's an injection in the neck, which is really only used in research settings. Data about exercise is interesting, and I think I'll stop there and let Stacy weigh in about what do you tell people about exercise and symptoms?
Yeah, so
Yeah,
let's.
so as I say, I'll jump in. So when we look at exercise, it's interesting because people just say, oh, exercise and strength train, but they're not being prescriptive in why, what, duration, intensity, any of the things that really matter. Because we're talking about the hormone chaos, right? And we're seeing changes in our blood lipids and our mitochondrial function, which affects it. The conversation between the liver and fatty acids that increase that visceral fat. We're seeing the changes in our insulin sensitivity. As an exercise physiologist, I look and go, well, that's just like a younger clinical person who has metabolic syndrome or, needs to instigate some kind of exercise to help clean these things up. So when we're talking specifically about exercise and we hear the 150 to 300 minutes of moderate intensity exercise and strength training twice a week, I want to bring everyone back down to the fact that that's male data and it's general pop, right? And so they have really confounded all of the things and have put women in, but they've just skewed it. And the majority of that research has been done on men. So when we're looking at women who definitively age at the onset of perimenopause all the way through postmenopause, we have to be very prescriptive from a physiologic change perspective. So if we're looking at what's happening from a skeletal muscle standpoint, we can't rely on estrogen to send the signals to build lean mass, bone, create a powerful contraction, to maintain the strength and integrity of the muscle. We need to look at an external stress. And the external stress isn't walking. The external stress isn't lifting light weights for 10 to 20 reps. We have to look at doing some intensity work, some really short, sharp, high quality, low volume, and we have to look at strength training. We have to look at instigating a central nervous system response that's going to take the place of estrogen, that's going to signal the muscle that we have to have more lean mass, we have to have a stronger, faster contraction rate, and we have to have a really tight, elongation of actin and myosin that creates a really strong contraction. When we look at lipids, and that's the big concern, right? Where we're having a lot of visceral fat, and it comes from what we call esterified fatty acids. So this is a way that free fatty acids change their molecular structure, and the liver reads it as, oh, we need to store this as visceral fat. If we're doing specific high intensity work, it creates a conversation from the skeletal muscle to the fatty acids and the liver to say, hey, wait, no, we don't need those esterified. We need those to come in and work in the mitochondria so that we have some fuel for contracting muscles and we have fuel for contracting muscles at rest. So now we aren't having the signal to store visceral fat. We're having the signal to change the molecular structure of those esterified fatty acids to then be used as a fuel. So when I look at all the things that are happening, it's the prescriptive aspect of exercise that we have to be very conscious of. And we can't just blanket say 150 to 300 minutes of moderate intensity and 2 times the strength training. And of course, people who are just starting to move, it sounds really overwhelming. So of course, I want people to move, right? We start somewhere, baseline, get up, start walking, because it's not what we're doing now for the next 6 weeks, which people think, oh, it's a diet, three months, and I'll see change. No, it's something we want to start now that we can keep doing for the rest of our lives. And it becomes that lifestyle thing. Like I'm going to get up and I'm going to do 10 minutes of some stretching, and then I'm going to get into maybe 3 sets of 30 seconds high intensity work, and then that's me. So it doesn't take a lot of time. And I think that's the fear where people think, oh, I've got to put exercise in and it's a chore. It's not. It's like brushing your teeth. And it becomes part of what you do to improve overall health. And we know that strength training is one of the best things to add in for neuroplasticity, dementia attenuation, reducing the risk factor for Alzheimer's, as well as doing that high intensity work for lactate production, because women have less of those fast twitch lactate type fibers. And we need to instigate that lactate production in order to maintain really good brain metabolism, to again start to attenuate some of the risk factors that we see with Alzheimer's and dementia.
Yeah. And
And I would just jump in here because when we are talking with these perimenopausal and menopausal people, we're talking about 2 different things. We're talking about symptoms, but we're also talking about long-term health, and those 2 things are complementary, but what you're talking about is so important because, falls and, those are the things that as we age, they really all of a sudden take our trajectory from independence to dependence, and it seriously impacts our quality of life and our lifespan. So, even though I'm talking with people about managing hot flushes or night sweats or whatever, there's always this other conversation. So I don't prescribe exercise to manage hot flushes, but I sure prescribe it to manage all the other things that happen as we age, for sure.
yeah, and I want
One
to
of
sort
the
of,
things that we
Stacey, I want to dive in a little bit to what you
Yeah.
said. That was really interesting, and there was a lot of information there. So I think we can maybe unpack it a little bit for people who are a little overwhelmed.
Yeah,
So, because
sorry.
you talked about sort of the guidelines, and you talked about high intensity, and you talked about strength training, and so I know you work with a lot of athletes, and they must come into you, and they're
That's the
like,
misconception.
yeah,
I used to work with a lot of athletes. Now I work with a lot of women who are just active and they
yeah.
want to stay active.
Well,
So,
that's sort of what I
yeah.
mean, though, is that people who
Okay.
are kind of already exercising, they may know that they want to do this. They may know that they want to, stay strong, get stronger, things like that. And that you have prescribed for a long time to lift really heavy, which I appreciate because I started doing that after you were saying lift heavy shit for a long time. And I think it's made me stronger and sort of pushed me through some plateaus. And I think that can be very effective. But we do know that there are a lot of studies on lower weights, higher reps that can also make people stronger. And for people who are just starting and have never lifted, can you explore that a little bit? Because you also say
Yeah,
that people need to just
absolutely.
move.
Yeah. So there's 2 parts of it. One about hot flushes, and we see that regular high intensity or sweat sessions can help moderate and reduce the frequency of hot flashes. We also see things like sauna exposure, where we're looking at creating a really intense heat response, can help attenuate the symptomology of a hot flash. So there are other ways that we can look at exercise and external stresses, because that's part of one of the biggest reasons why people don't want to exercise is they feel uncomfortable in the heat. So we look at how do we mitigate that with some of the intensity work. When we're looking at the literature out there, and most women who are in their 40s onwards grew up in the 80s, 90s, some of the 70s, right? Where strength training wasn't the thing, where we might do fat burning with our pink weights. And yes, any kind of loading is going to increase our strength. And we're looking specifically at what's happening when we start adding load. And we want to keep adding load to build that strength. We also want to keep adding load to build muscle tissue. But we get to a tipping point where we see that the higher reps will instigate a little bit more of that muscle building hypertrophy, but there is not a strength improvement. So when we get to a point where we're so comfortable in lifting our 10 to 12 reps, 3 sets, 4 sets, I always turn to women and say, okay, I want you to put those dumbbells down and I want you to pick up the next one. How does that feel? Can you do 8 to 12 reps with that? Yep, I can do 8 or 9, no problem. Put those down, pick up the next one. So there's a progressive way of becoming more comfortable in the movements as we add load, because I don't want anyone who's never had a history in strength training, but is really long, loves walking, maybe does some running, maybe does some fit classes, but has no history in strength training. I don't want them to go to the gym or jump in with people and go, here's a barbell, let me do the work. Because the risk factor for injury is really high. We also know that in perimenopause, soft tissue injuries are really prevalent because, again, estrogen effects on the soft tissue. We see plantar fascia, frozen shoulder, all of these things because of estrogen and the effect on tendons and ligaments. So we want people to phase in. I always tell women that I want them to learn how to move properly. It could be you are just doing body weight squats and seeing what your range of motion is, how you're landing, how your knees are. You might get a personal trainer session to assess your movement capacity, and then we start adding load. And again, it's over the course of time. It might take you a year to learn how to properly lift heavy. And a lot of women think, oh, well, I haven't progressed and it's taken me a year to learn how to do a heavy 3 or 5. No, you look where you started. You started not even able to pick up a barbell, and now you're picking up a 35-pound barbell. And that is progression. So when we're talking about lifting heavy and strength training, it's relative to where you're starting. So we want people to understand strength training can be just in your house. First thing up, we're doing body weight stuff. Then maybe we're putting a backpack on with some household goods to add a little load. Then maybe we invest in a kettlebell and look at doing some kettlebell work. Then maybe we get some friends and we go to the playground and we're doing some stuff on the monkey bars, or maybe we're doing some tire flips in some of the playgrounds. I know they have them here, but probably not in the States. And then you can start like moving into more specific realms of strength training. And there are a gazillion really fantastic apps that are out there that allow you to watch and learn. You grab a friend and maybe you meet 2 or 3 times a week and you're doing that strength training session together for 20 minutes. So there's always a place to start. And that's when I'm like, I want everyone to move and feel comfortable in the movement, because again, it's not like a 3-month stint. It's what are we doing now that we're going to progress in a year from now? And then what are we doing in a year from now that we can do again, 6 months, another year, 5 years, 10 years down the track?
I love that. And I think it's really important because it's so easy to stay in your comfort zone. Like, especially as we age, like that desire, that drive to get into the red zone sort of disappears. And so this idea that you can get better at any age by starting slowly and moving through it and working up to those heavier weights, and it can break you through those plateaus and really make you stronger postmenopausally than you were before if you're new to lifting. And I think that is such an important message.
I have
I always like
to say that, I'm in the best shape of my life here at age 55 or 60. And that is absolutely, that's very doable. And it is the reality for a lot of my patients.
I like to send women to the Instagram site Train with Joan. So she's a woman who was in her mid 60s and was diabetic, severely overweight, had lots of clinical issues, and her daughter owns Wonder Women personal training. And so she's turned to her daughter and it's like, I don't want to be like my husband who doesn't care. I want you to help me. And now she's in her 80s and she's bench pressing 110. You know, she's deadlifting close to 200. And she just does strength training. She's on a massive crusade for women who are older to understand strength training. And it's been a journey. And you can see her journey through that. But she's such a huge advocate. And to see someone her age in the gym with confidence lifting, I was like, I want that to be available to every person who is on this journey with us.
Mhm.
Great advice. I'll definitely check that out. So we're going to pivot to hormones in a moment, but I have one more question about cardio, because you talked about the guidelines, 150 minutes, moderate activity. And I have a lot of friends, and mine might fall into this category, that gets a lot of psychological benefit out of, going for a run with the dog in the hills, joining a friend for a run, skate skiing at this sort of lower zone 2 intensity. And so there's a lot of psychological benefit from that, in addition to physical cardiovascular benefit. So how do you reconcile that? Because you are very interested in pushing sort of high intensity and weight training. So how does that fit into your program?
I'm first to admit that I love going out for 2, 3, 4 hour gravel rides and just cruising around. Like, that's my default. That's my complete soul food. And I don't want to take soul food away from anyone, right? But when we're looking at time constraints and the maximum bang for your buck, it's small bits of high intensity work with strength training. So you might do 2 true high intensity sessions in a week. Could be sprint interval training, like your 30 seconds or less, as hard as you can, and you have 2 to 3 minutes recovery between each. Or it might be a little bit lower in the intensity, but still around 80–85% of your max when you're doing every minute on the minute for 4 minutes and 1 minute fully recovered. And then that's all you really need to do for all the benefits that we talk about with high intensity work. And then it's your soul food. Just don't make the soul food the only thing that you do, because that's not what's really going to instigate change. Because we are in a society where no one wants to be challenged, no one wants to be uncomfortable. We all sit in rooms that are 68 to 72 degrees. We have cars now that have cameras, so we don't really have to pay that much attention. Everything has just been technologically condensed to make people not really be uncomfortable. And we have to challenge ourselves. We have to be comfortable with being uncomfortable in small bits of time to really instigate change, because the body likes to be challenged. Otherwise, we become like the floating figures in WALL-E. We don't want that. You know what I mean?
Yeah. That's great. Okay, well, I'm going to pivot a little bit. That's fascinating. Karen, let's talk about hormones, hormone therapy. So why does it have such a bad rap? When should someone go on hormone therapy? And then we'll talk about sort of when to come off it in just a moment.
Yeah, really, the pendulum is swinging now. It used to be people were like, I don't want that. It's poison. It'll give me all kinds of bad things. Now everybody's like, why can't I have it? I want it. And, I hear it does great things. So, the truth is not either of those exactly. The reason it got such a bad rap is this huge trial that was really needed and necessary. And it wasn't a bad trial. I get sad when I hear people bashing the Women's Health Initiative, because it actually was a very good study and it told us a lot. It just got overinterpreted and kind of, we used data that was related to women 65 and over to make decisions about really younger women, and that wasn't really appropriate. And we know that better now. So what we know now is that younger people, meaning under age 60 or less than 10 years out from their final menstrual period, either or, so under age 60 or 10 years out from their last period, will respond differently to hormones than older women. And what happened in that trial was that they enrolled women on hormones between the ages of 50 and 79. So they were putting 75, 76-year-old women on hormones who had never been on them before. And they're the ones who had the heart attacks and the strokes and all those things. So we don't start people after age 65 in general on hormones any longer. But if you're 48, 50, 52, 55, even even up to age 60, without contraindications, you can actually gain tremendous benefits from being on hormones. And that's what we know now that we didn't really know then. And that's why hormone therapy got such a bad rap. And we are still trying to unpack that messaging, because when that data came out, 40% of women were on hormones. And now less than 5% of eligible women are on hormones. We're at like 3%. And a lot of people could gain some benefits if they were on it, and they just aren't getting that message. So that's really what the rest of my career I'm going to spend at Stanford or wherever, just really preaching this and saying, this is not one size fits all medicine. You really have to see somebody who can help you figure out if this is the right thing for you or not, because in many cases, it's tremendously beneficial.
And let's say someone decides to go on it and it's the right thing for them. So how long can they safely stay on it? And then when you come off, do you just go through menopausal symptoms again, just at a
No.
later time, or is it somehow a different transition?
Right. Well, I'll just say I'm 66 years old, and they will get my hormones when they pry them from my cold, dead hands. And so that I will answer that question with that caveat. But if you started at the right time and you haven't developed any contraindications, there's no age at which we automatically stop. So the people who probably should not take hormones, or actually should think about it really carefully with a provider, would be somebody who has breast cancer. Not 100% of the time. Sometimes people can be on it if they have a history of breast cancer, but it's a nuanced discussion. But in general, people with breast cancer, people who've had a heart attack or a stroke, or people who've had a blood clot in their leg or their lung or their brain, those are kind of the big categories of people who shouldn't take it. And then also if they have active liver disease or gallbladder disease, or a few other kind of less common categories. But assuming that you start at the right time, you don't have any contraindications. There was a big trial, or a big study that just came out in May last year, looking at women who started at the right time and stayed on it past age 65. And all of the outcomes were either positive or neutral, except for a very small increase in risk in breast cancer, which was about 4 extra cases per 10,000 women, so per year. So not a huge negative outcome. But other than that, they died less frequently of all causes, and they had no increase in cardiovascular deaths or deaths from breast cancer. So in general, if people start at the right time and stay on it, you're going to gain those health benefits. And there's no age that we automatically stop. If somebody develops a contraindication, if they have a heart attack or a stroke, or they get breast cancer, we stop them cold turkey. We just stop. But in general, if somebody's trying to just go off for their own reasons, we taper, because otherwise it does kind of trigger hot flashes. So that's really the main thing that people notice if they stop quickly. Otherwise, you can taper it, and over 6 months to a year, just drop the dose, and then people can tolerate that pretty well without a lot of side effects.
I want to jump in on that study. They were done on sedentary women. There's no indication to exercise in there. And that's the misnomer that I'm finding, is people feel like they have to be on it, or they really want to go on it because it's going to solve everything. When we look at it, I tell people it's a tool in the toolbox, but let's look at exercise with it. Because there's a lot of women are like, it's going to stop my body composition change. And we know that.
So many questions for you about this, Stacy.
Let's do it.
So hormone therapy is recommended or FDA approved for 4 things. So hot flushes and night sweats, vaginal symptoms, premature menopause, young women who go through menopause under age 40. And then the other is decreasing the risk of osteoporosis in high-risk women. So not treatment of osteoporosis, and that's only because that study hasn't been done. It's approved for osteoporosis treatment in other countries, but not in the United States. So prevention or decreasing the risk of osteoporosis. And it's not recommended for muscle strength or any of those things, And so how do you think about that when you're talking with women?
I tell women that
Sorry,
if there's,
Anne, I just had to jump in with that
oh
question.
no, it's fine.
That was my
I
next
love
question,
it.
so you just beat me to
Because
it.
this is the conversation that everyone wants us to have, right? Because I come from one side of the non-medical, and then you're coming from the clinical side.
Right.
So when I'm talking to women about it, and I mean, I have friends who are breast cancer survivors and they feel FOMO because they can't go on it. And they're hearing all this stuff from all the influencers that everyone needs to be on it because it helps with everything, including brain. When we look at the external stresses of exercise, we can instigate a better change, but people had to put in the work. And there's another friend of mine in the industry, and we say there's actually two camps when we look at it. We have one camp of women that want to take the hormones, do Pilates, and pretend they're still in their 30s. And then we have the other camp of women that really want to instigate change. And so they're willing to put in the work. And I really want to push everyone to understand that even if you go on MHT, I'm not saying HRT, but menopause hormone therapy for all the symptomologies, because mood and rage and everything is just a massive factor. You have really bad hot flushes. You're having just a really decreased quality of life. Then yes, but it's a tool in the toolbox. If you want body composition change, you want to improve your blood lipids, you want to improve your brain health, you still have to put in the work of exercise. And that's the thing that's not being discussed when I said, you know, like the dose and the intensity is really important, because people will say, oh yeah, menopause hormone therapy and exercise. And people are like, oh, I'm walking, but I'm not seeing any difference. It's because we don't have the right things out there to really identify. These are the things we want to do. Menopause hormone therapy is not uh, uh, it's not off the table, right? And it's not completely on the table. It's in the toolbox. It's the same as some of the other pharmacological aspects. We see other things like acupuncture and cognitive behavior therapy. All of them are in the toolbox.
So
And
I
that's
have
why,
to ask you, I have
yeah.
to ask you. So, estrogen causes a small but measurable impact on lean body mass. We know that. And so
Mhm.
it will shift you a little bit more toward muscle, not a huge amount, but a little bit. And it does tend to mitigate that spare tire, a
Mhm.
little bit and improve visceral fat. How do you recommend to people that they try to decrease their visceral fat? That I would love to know how you advise people. What, like, are there supplements? Is there particular kinds of exercise? How can they impact their visceral fat stores?
Yeah, there's been some really cool studies that have come out in the past 2 to 3 years. We're looking at one, strength training, and it doesn't really matter the loading of strength training, but we're looking at minimum 3 times a week of total body strength training. And it creates that exerkine conversation where now we're not storing visceral fat. And we see a significant decrease in abdominal fat in women only. So the strength training is really, really important. The other part is when we look at true high intensity work. So we have the moderate intensity interval training, we have true high intensity interval training. And the studies that I've been seeing have been 20 seconds of really, really hard as you can for over the course of 10 minutes. So it doesn't take a lot. And that instigates change in blood lipids and a reduction in visceral fat. We also see that both of those will help with lean mass. So when women are like, oh, I want MHT for body composition, I tell them it'll slow the rate of change, but it won't stop it, because
Yeah.
age comes into the play as well, right? Because we see an age-related decline in lean mass. We see an age-related increase in visceral fat and subcutaneous adiposity. So you do have to put in the work, even if you are going on MHT. And that's the big message that I tell people. I'm like, you can't use MHT for body composition. It'll slow the rate of change, but it's not going to stop it.
Okay, thank you. That's so helpful.
Yeah.
And Stacy, I am confused about something because in animal studies and some human studies, estrogen impacts muscle in so many ways, right? It increases repair, it changes the myosin chain so that you have stronger contractions, it stimulates satellite cells, all these things that should make a real difference when you're combining it with resistance training. But, if you do sort of a search through the literature, it's about a 5% benefit with hard resistance training if you are on hormone therapy. So why isn't that a bigger effect? I mean, we see this loss of muscle mass when we go through menopause. You think you give the hormones back and you do resistance training, it should have a synergizing effect. It doesn't seem to very much.
It doesn't, because one of the things that's happening in perimenopause is we're having a downregulation of our receptor sites, right? And that's part of aging as well. We also have to look at the pharmacological dose of the MHT, because when we're looking at what it does, it's a very low dose to attenuate the changes that are happening and to attenuate symptomology. It's not the biological dose that we used to have with our menstrual cycle. So when we're looking at what MHT is doing, it's a small dose, and we know like patches, you have an increase and then it decreases, and that's why you have to change it every 2.5 days. We look at gels as well, the transdermal, there's a big hit and then it drops off. And so it's like a massive pulse, but it's a different sequence than what your body used to produce. So the receptors aren't getting the same stimulation, and we're also having a downregulation. So when we're looking at applying exogenous estrogen as MHT, it does not have the same biological effect on the body as endogenous estrogen. And when we're looking at things like oral contraceptive pills in younger generation, and we're seeing the estradiol dose of 20 versus 30 micrograms of estradiol, we see women who are on a 30-gram dose have an increase in lean mass, but not strength, because it is a larger dose of estradiol, because you're taking a much, much larger dose every day. It's about 500 times the cellular effect than your natural cycle. And we're not doing that same kind of dose with MHT. It would be really harmful for the most part to put someone on that. So we're looking at the dosage and how it affects the body. With MHT, it doesn't have the same endogenous response. And that's why we're not seeing massive gains in lean mass and bone.
And I'm just going to tell our listeners, when you say MHT, that stands for menopausal hormone therapy. And just in case people didn't know what that was, it used to be HRT. We don't call it that anymore. One of the things I think is so interesting is, healthy aging is all about staying strong. It's all about that. And, so to me, that's osteoporosis prevention and muscle strength. And so, and those are really two different things, and there's some overlap, but there's some difference as well. And, falling and breaking a hip, if you're elderly, is an absolute disaster. 1 in 4 women will die, and another 1 in 4 will be permanently disabled. And so it is absolutely about prevention, not about dealing with it after the fact. And so when I'm talking with women about estrogen and bone health, it will increase bone mass by about 5 to 6% to start on estrogen. So that in and of itself is really powerful. But, like in trials like the Lift More trials, where they're looking at bone impact, really exercise, even heavy lifting, only gives you about a 2 to 3% bump. So it doesn't give you the bump that estrogen does. And do you interpret that in the same way, Stacy, as I'm presenting?
So when we're looking at the multi-directional stress on bone, lifting does instigate some of that. And that's why we're only seeing a small increase. But jump training is a multi-directional stress. And I'm not talking about plyometrics. We look at a lot of the new research, some's coming out of Oz, some coming out of here in New Zealand, some coming out of, I think it's even the Mayo Clinic or Cleveland Clinic. We're looking at very low jumping. So you're not jumping really high, but you're landing hard. So you're not landing how we've been taught with soft knees and absorbing through our muscles. We're learning to absorb it with our skeletal system. And we see an increase in bone mass over the course of 6 to 12 months that is around 6 to 8%. So we can see women going from low normal into the mid normal with jump training and no estrogen. So
Interesting.
when I think of someone who's at a really high risk of osteoporosis, and I'm in that, I'm not on hormones, but I am really diligent in jump training and doing heavy lifting, and my Z score is still around 2. So I'm really good with bone density, and we'll see how that progresses as I get older. If there is an intervention, then I wouldn't hesitate to use estrogen if I'm starting to get, and what I'm doing isn't appropriate. So again, it's the dosage, right? Like, how do we complement them together rather than just one or the other?
And
Right.
so that, that's great information, but there are a lot of people out there who have joint issues, that have injuries, and the idea of, slamming down with, I hear you're having surgery, sorry about that. So what can people do if, you know, they look at you and say, there's no way I'm going to be able to do that. I'm going in for a knee replacement. So how do you reconcile that?
Yeah, and we can look at other ways instead of well, a lot of people think jumping as in jump rope or jumping off a step, but any other kind of multi-directional stress. It could be overhead ball slams. It could be plyo push-ups against the wall where you're getting some of that impact through your hands. There's lots of ways to modify what we call jump training, and it doesn't take a lot. It's 3 minutes a couple of times a week. And it's just about instigating a different type of stress on the body that's creating a whole bunch of different responses. Because, like, if we're doing plyos against the wall isn't moving, we are. So we're absorbing the stress in so many different ways from our hands, our wrists, our elbows. And if we're really close and exploding off, then we have to contract the core to keep strong, and that creates another different stress in the pelvis area and the lumbar spine. If we're doing overhead ball slams, it's a light ball, but you're pushing down as hard as you can. And so that contractile strength is akin to an impact. So there's lots of different ways that we can put it in, with the idea that, yeah, like I have a bad knee, and there are other women who have really sore joints because of going through perimenopause. The idea of jumping isn't that pleasant.
And some people, their bladder can't tolerate the
Yeah.
jump. You know, I mean, it's like they just leak. So you have
I
to
know,
just,
that's why I'm like pelvic floor specialists. We got to get them in because they don't, like you go through perimenopause and the pelvic floor is a muscle. You're going to lose strength. You have to learn how to retrain it. But yeah, there's so
By the
many
way,
different pockets in it.
we
Yeah.
have a whole article on pelvic floor health
Yeah.
in the most recent newsletter. So
Yes, I know. It was great.
um, that's great. Well, I think we could continue talking for hours. This is fascinating, but I want to open it up to some of the questions, because I see we have like over 150 questions that have come in over
Whoa.
this period. So Rachel,
Oh.
you want to
Okay,
share?
we'll have to do a part 2, Karen.
or a series. Let's just do
Yeah,
this once
let's
a
do a
month. And
series.
yeah, that'd be so fun.
I'm
That would
there.
be super fun.
The questions have been coming in fast and furious, so I'm really excited. And for everybody that's putting in questions, what I've been trying to do behind the scenes here is put them into categories. So hopefully everybody will get their questions answered. So really early on, you both started talking about these health issues that start to pop up, both peri and postmenopausal. And there are a lot of women in the chat saying, all of a sudden I have type 2 diabetes, I have insulin resistance, I have osteoporosis. And the questions that have kind of been coming from two areas are, what do I do about this in perimenopause? And then if it's happened to me, I go and I have my A1C is high, my triglycerides are high, I've gotten a diagnosis, what do I do after? So maybe adjust it from those 2 time points. What do you do to prevent, perhaps, and what can you do once you've received a diagnosis?
Right. Well, the hormone therapy isn't going to cure diabetes, but it does improve. It improves, you get improvements in glycemic control and insulin resistance, but we don't use it to treat diabetes. So obviously, if you have a new diagnosis of osteoporosis or diabetes or hypertension or whatever, you need to get that dealt with primarily. You need to have that treated and controlled. It's super important because controlling chronic conditions is one of the mainstays of treatment of dementia prevention. So heart health is always brain health. And so when we are doing things to keep our heart healthy, we're keeping our brains healthy. And one of the mainstays of that is controlling any chronic conditions. And so, that's really important. But those conditions can often be reversed or completely cured with lifestyle changes. So it is really important to be looking at things like a whole food plant-based diet and exercising appropriately and those sorts of things. Hormone therapy can be helpful. When people have, for example, elevated triglycerides, putting people on oral estrogen will make that worse, but transdermal estrogen does not. It has a neutral or even beneficial effect on lipids. So again, we don't use it as treatment for that, but you shouldn't hesitate to go on hormone therapy for the indications that you might have, even if you do have diabetes or hypertension or something along those lines. Osteoporosis, estrogen certainly is effective for improving bone density, but we also have other drugs for that as well. And then always exercise. Exercise is super important for all of those things.
Yes, exercise and diet. We didn't talk about our gut.
Right. Oh,
Yeah.
right.
We
I
love
have,
that
I have
question.
questions coming for you about that. So let's
Oh, okay.
see if you want to answer the sort of, what to do. I think exercise is probably the space that let's start there, and then I'll transition to some of the nutrition questions.
Yeah, so when we're looking at like diabetes, one of the most powerful things that you can do is go for a 10-minute walk after a meal. Because we're looking at how we're going to pull glucose into the muscle without insulin. And one of the biggest drivers of that is exercise, because it'll translocate what we call GLUT4 proteins, which is kind of like opening the door. That is a key, is opening the door and saying, come on in, glucose, and don't worry about having a special locksmith, which is insulin. Let's just open the door and come on in. So just a small 10-minute walk after dinner or lunch or whatever, it makes a huge difference in controlling blood glucose. When we talk about the anti-inflammatory effects of estrogen that decrease when we lose estrogen, this is where we look at using additional things like turmeric in the diet. We look at using or trying to consume a lot of anti-inflammatory foods. Again, exercise, massive for anti-inflammatory, because if we're doing it correctly, we have a post-exercise anti-inflammatory response. So that's where that moderate intensity isn't a strong enough stimulus. We either have to look at really super low intensity to kind of help the body relax and get more parasympathetically activated, or we have to look at that true high intensity work. So if we're doing true high intensity work, then we're going to have a post-exercise response of growth hormone, testosterone, a drop in cortisol, and a really strong antioxidative and anti-inflammatory response, which then feeds through the entire body. And then that helps with the lipids, it helps with the A1C. And again, exercise is going to help with the bone density, it's going to help with insulin sensitivity. So as I was saying, we have to look specifically at dosage and intensity, and that's an individual case by case.
Awesome. I'm going to stick on the topic of body composition just for one more question, and then I want to pivot to nutrition because there's a lot of questions coming in about that. So specific to body composition, the question that just continuously keeps coming up is bone and bone health. And I know that you've both addressed this a little bit, but it also goes to this question of when should we start hormone therapies if we have a risk for osteoporosis, if we've already had a diagnosis perhaps of osteopenia. Should hormone therapy be started in the perimenopausal times to start to address these issues that are maybe not the major indications for hormone therapy, or should you wait until you are clearly in a postmenopausal time to start thinking about this? And I'll put it to Karen for hormone replacement, or for hormone therapies, excuse me, and then to Stacy for more of the lifestyle questions here.
Yeah, great question. Really great question. So risk factors for osteoporosis are small body frame, Caucasian race, alcohol intake, more than a couple drinks a day, family history, mom with a hip fracture, rheumatoid arthritis, long-term steroid use, smoking, those are kind of the big ones. And if you have those risk factors, the guidelines used to be that you would get your first DEXA scan, your bone density scan, at age 65. And that is so past the time, I mean, oh my gosh, 65. By then, so much of the damage has already happened. So now we're moving more toward getting the first bone density scan around the time of menopause, which is average age of menopause is 51, 52, somewhere in there. So if you haven't had a bone density scan, and especially if you have some risk factors, it's important to get that done quite a bit earlier. If you go through premature menopause, somebody who's gone through it at an earlier age for medical reasons or surgery or something, you should have a bone density scan whenever you are menopausal. I just ordered one yesterday on a 19-year-old who is premature menopause because of medical treatments. And so it's really about your menopausal status, not about your age. Once you, now I got myself confused.
When to start it?
Timing.
I'm having a little bit of a little bit of brain fog, menopausal brain fog. Yeah, so you should think about hormones because they are really beneficial for your bones. You will get a 5 to 6% bump in your bone density when you start hormones. And when you stop at any age, you will get an accelerated decline. So those benefits do not persist if you stop hormones. So you definitely need to take that into consideration. And yes, it might be appropriate to start in your 40s if you have symptoms or you have risk factors that would indicate that you would benefit from it. So yeah, absolutely you could. Mm-hmm.
And Stacy, the follow-up questions that are just coming in fast and furious are, do you need hormones? Can you do this? Can you build bone back up without hormone therapy? And what would be the recommendation for that? And I will add a little caveat here. There's a lot of questions coming in about the high intensity and the jump training that are like, I've tried it, I've gotten injured, where do I start?
Yep. So I always tell people never too early. Like even in your early 30s, start doing strength training, start putting in some plyo when you can. And then as you get older and maybe you can't jump as much, having joint injuries, there's a new app that I like to tell people about. It's called OsteoGains. And it's all about how to do proper jump training when you have low ability for jumping to improve bone density. If you are someone who has that diagnosis of osteopenia or osteoporosis, you can put it hand in hand. As Karen's saying, we see this increase with hormones, but you have to put in that training as well. You have to put in the exercise training in order to maximize the amount of bone you can build with the estrogen therapy. And then when you come off it, you have that bone and you have that ability to maintain bone density and keep building it. And I think, again, that comes into, well, how do I start? What do I do? Start now, start small. If you're looking at jump training, maybe we're looking at OsteoGains or some of the other things that are coming out of Oz about how do we jump properly. Maybe you're doing it once a week and then you're building up. Again, it's not do everything all at once. It's start small and know that the body responds really quickly. And for women, we have a really fast uptake of exercise stress and adaptation. So start small, gradually build, and then over time, it might take 3, 4, 5 months. You're going to see an increase in your bone. I have a friend who is a personal trainer, and he works over with the Emiratis, which is over in UAE. And he has a cohort of expats that are all osteopenic, and they don't have accessibility of hormone therapy over there because it's just not in the cadre of things in United Arab Emirates. So they are all doing heavy lifting and jump training. And over the course of a year, they all went from osteopenic, osteoporotic to normal bone density. So it is possible. It's just you have to put in the work.
But just a follow-up question on that. So as people start this and they're feeling soreness and pain, and maybe this is more of a question for a physical therapist, but how do they know when it's too much and how do they know when it's just soreness and they need to push through and keep going with it?
I never tell people to push through, especially when you're just starting something. If you're having DOMS or muscle soreness, that's something different than if you're having joint pain. If you're having joint pain, then we have to reassess what we're doing. Maybe we're putting in more mobility work before you're doing it. Maybe we're using some voodoo flossing, which is a type of blood flow restriction, but it's not scary blood flow restriction. It's just a way of warming up the joints. There's lots of methodologies, but again, it's an individual basis. So like if we end up doing a series, we can do a whole like conversation around that kind of stuff, but there are definitely ways of attenuating and stopping that joint pain and allowing people to progress. But again, it's small doses over a period of time because it's the consistency that matters, not a large dose and stopping.
All right, let's stay on body composition, but now let's turn to some nutrition. So Dr. Stacy and Dr. Karen, you are not going to be surprised that a lot of the women are very concerned, and you both mentioned it about that visceral fat, the sort of, fat around the middle. And we've got a lot of questions about, let's say on macronutrients to start, protein and carbohydrates. A lot of women are like, we've been socialized to think that carbohydrates are bad, 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 and they are going to be straight to the middle, and we should stop eating all of our carbs. And then everybody's like, but wait, there's so much there's so much hype around protein. How much protein should we be getting? Is this helpful? So I'm going to start, Stacy, with you and think about, what is this balance of carbohydrate and protein? How does it support body composition? And then how does it support this exercise regimen that you are talking about?
Yeah, just stop for a minute because I'm going to go get my toast because, I'm really needing some carbs. Yeah, I don't like the rhetoric of women should have no carbs, because when we're looking at basic energy needs, women need more carbs to begin with. We have an area in our brain, the hypothalamus, that's super sensitive to nutrient density, regardless of how old we are. And the more we perturb it, the more our brain is like, hey, wait, we're in a low energy state. We're not getting enough carbs. We're not getting enough calories. I'm going to start down regulating. And I see this in so many women who are starting to go through perimenopause because their body comp changes. And we've been conditioned to think less calories and less carbs. In fact, we need more carbs and more calories, especially to support our circadian rhythm. So when we're looking at carbs versus protein, we need carbs, but we need to be conscious of what kind of carbohydrates we're eating. So we see in the 3 to 4 years before we actually hit that one point in time menopause, there's a significant decrease in our gut microbiome diversity. So what happens is we have an increase in the gut bugs that say, hey, let's hold on to body fat and increase the amount of body fat. And we have a decrease in the gut bugs that say, nope, we want lean mass. So we have to look at really increasing the amount of fibrous fruit and veg that we have, and whole grains. Like, that should be the mainstay of our carbohydrates. When we're talking about protein, the information out there about around 50 grams for women, or about 0.6 per pound of body weight, is based on an RDA that is the minimum amount that a sedentary person needs to avoid malnutrition. I reiterate that. It's the minimum amount a sedentary person needs to avoid malnutrition. If we are trying to instigate change, if we are trying to instigate better health, we need more. As we get older, we become more resistant to the building properties of both exercise and protein. So we try to have women who are in perimenopause and older hit at least 1 gram per pound of body weight of protein per day. And we look at skewing that throughout the day. We ideally want late peri, early postmenopausal women between 1 and 1.1 grams per pound. And people are like, whoa, that's 130 to 160 grams of protein a day. How do I get that much? I'm not saying that you're throwing down a lot of chicken breasts. I'm saying if we're looking at all the different types of proteins that are out there, we're getting it from edamame, green peas, tempeh, tofu, chickpeas, black beans, lean chicken, lean beef. We're looking at fish. We're looking at all the different things that can come on a plate and give you 30 or 40 grams of protein. So as we start thinking about it, it's not animal or plant. It's a combination of the two, if that's how you are looking at food. Again, it's plant forward. Plant-based is great, but you want to have all the lean proteins possible. And full disclosure, I've been vegan since I was 14. So it's very possible. Like, I have added dairy in over the years, but just yogurt when I'm traveling, Greek yogurt when I'm traveling, and every once in a while, some whey protein to supplement. So it's very doable to hit those higher grams of protein and not be afraid of it. It's just we haven't had that conversation. It's always been about fat and carbohydrate. So protein is really important for aging, for muscle quality. We want muscle centric. We want to think about how are we growing our muscles? How are we preserving our muscles? Because then that also helps with bone. We know we need protein for bone as well.
And a lot of those first things on your list, which were plant-based, also give you the fiber. So you
Exactly.
just getting the protein alone, you're getting the protein and the fiber together, which is something you commented we needed as well.
Right,
Exactly.
and calcium as well.
Yes.
So they're high in calcium, high in protein, high in fiber. It's like so much bang for your buck.
Win. Yep,
Mhm.
exactly.
All right. So
It's so simple, but people don't want to do it. because it's too simple. They're like, what? I just eat plants and
Well,
veggies? What?
since you said you've been vegan since you were 14, I have to tell you, I grew up in Texas, and
Okay.
in my family, it was not, we didn't feel like we'd had a meal unless we had the steak that was falling off our plates on either side because it was so big. And then, so over the years of my life, I've really modified that. And then I got lifestyle medicine certified a couple years ago and really started doing this. And I have to tell you all, my hemoglobin A1C went from 5.8 to 4.8. I was running around the clinic bragging about my A1C, and my cholesterol dropped 30 points or something. And I'm not even that, religious about it. I will still occasionally have my burger and fries or something. And so, my message to my patients is small changes can make extraordinary differences. And so I'm totally motivated by what you're talking about, Stacy, but I have to tell you, a lot of my patients are like, I used to go to the gym at 5 a.m. I was the first person there. I was hard body. I loved it. I'm nowhere near that anymore. And I mourn for that person that I used to be. And I don't even know what to do now. I can't even get off the couch because I'm
Yeah.
just so, demoralized by it all. And I just always say, just put your running shoes by the front door and look at them as you walk by now and then, or get your barbells, your old barbells out and just put them somewhere. And then maybe drive by the gym and just look at it and kind of incremental, because motivation, I mean, we know what we need to do, right? But it's so hard to do it sometimes. And so I really just love your messaging. I think I've learned a ton. And I also want to say to the people out there who, if you're not doing all of these things, anything is better than nothing.
Definitely.
Mm-hmm.
And the 80-20 rule, which I always like to bring up. It's like we're human and we like the good things in life that supposedly are bad for us. Nothing is bad for us. It's the doses in the poison, or whatever the expression is. So I tell people 80-20. 80% of the time you're on it. You're paying attention and you're really on it. And then 20% is life. So you've had a really bad day and you eat something that you feel like you shouldn't. Doesn't matter. Tomorrow's another day. It's not going to ruin all the work that you've put in. Or if you're going on vacation, you're a bit conscious of what you're doing, but instead of eating the entire buffet, just have small bits of things that you really like, and don't feel guilty. If you have something that's really a nudging point and you're like, I really need to get rid of this extra fat, or I really need to bring down my lipids, then maybe it's 90-10. You just make little tweaks, but never give up some of the really good fun things, and don't feel guilty.
Don't do guilt. I don't do guilt anymore. I don't.
It is, yeah, it is something that you can't do anything about it. You inherently feel it and it makes you feel bad, but it's nothing. It's not a motivator. It's not something you can change. It's something that women get dumped with. Don't do guilt.
Nobody ever got unhealthy because of one day.
No, not at all. It takes months. So if you're conscious, years, really true.
Yeah.
Very true. For people who put weight on, I'm like, how long did it take you to put the weight on? It's going to take you some time to take the weight off. It's not an overnight thing. Just like putting the weight on is an overnight, taking it off is an overnight. So yeah.
All right.
It does
So there was a bunch of questions about supplements, that we have 2 minutes left. So that is not going to happen. So we'll tease this up. We're going to have to do a part 2 about nutrition and supplementation. But there was one question that I think would just be awesome, that just really struck me. And we are constantly sort of talking about menopause and the challenges that happen. And a question that really stuck out was, what are the benefits, whether it's biological or lifespan types of benefits, that could happen because of this menopausal transition? Are there positives here?
I just did a podcast with The Atlantic just on that topic. They said, we just want you to come on and talk about the good things of menopause. And so I think that's coming out in another week or two. So look for that. That's a great question and a wonderful one to end on. And I'll just say menopausal zest is a real thing. And that when people get through the process and get through the transition, they're happier in every area of their life. They like their relationships better. They're happier at work. they're happier with themselves. And it really is a time when there's just endless possibilities. And, you know, in a way, it's kind of like, you know who you are, and you've learned a lot, you've lived a lot, and it's a good time. So, you know, you don't have to suffer. Menopause is 100% unavoidable, but suffering is 100% avoidable.
Yeah. And I like to bring people to the outside of Western culture, because we're in Western culture and we see that women age out of life around 40. You see it in the magazines, the movies, and everything. That's why we haven't had these conversations around menopause. We look at other cultures and people are embracing menopause because now they're in a new biological state and they have freedom. Like they're free from the reproductive worries. They have a greater, wiser outlook in life. And I like to embrace those cultures where it's like, it's all part of aging. It's just our Western culture has put such a negative spin on it that everyone's afraid. When we need to say, you know what? It's a natural part of aging. And we are just entering more chapters in our lives. And if we look at popular media, look at how the men are portrayed. They're becoming more distinguished. And that's how I want Western society to look at women. As we age, we're becoming more distinguished and wiser and better at all of the things. So
And
that's
I
where
wouldn't be 30 again for anything. I wouldn't.
Mm-mm.
Well, that brings us to the end, and that, Rachel, that was a perfect way to end this webinar. And I want to thank our guests so much. I learned a ton. It was a great conversation. We're getting lots of claps and hearts from everyone, because I think this was so interesting for everyone. And look for more webinars from Stanford Lifestyle Medicine. We'll have more coming up in the future. And when we leave this screen, another screen will pop up with a notification about the Healthy Aging Conference that we're having on May 5th. And there'll be a little QR code if you want to go ahead and register for that conference. But again, thank you so much to Karen Adams and Stacy Sims and Rachel. It's been a wonderful hour and 15 minutes, and I hope we can do it again soon.
Okay.
Awesome. Thank
Thank
you.
you all.
Bye.
Thank you all. All right, Karen and Stacy, thank you so much. If you want to pop off, that's fine. Sharon and I will keep this open so that people can check out the Healthy Aging. Appreciate you both so much. Thank you so much. And I have to say, the chat is very in favor of a series and even a newsletter and ongoing conversation. A breath of fresh air has come over the chat many, many times. So appreciate you and your knowledge and everything that you have done for our group at Lifestyle Medicine here today.
Awesome. Thanks. It was fun. And good to see you again, too.
Yeah, likewise.
Yeah. Yeah. To be continued.
Be continued.
Exactly.
All right. Nice to meet you all, you know,
Yeah.
in real life, hopefully in person someday.
Yes,
Thanks so much.
definitely. Thanks,
Okay.
guys.
I'll hop off.
Bye.
I've got a dentist appointment. I got to run.
See
Bye-bye.
ya.
All right, team. And for anybody that's left, you can also check out our newsletter. If you have not registered yet, go to our website and you can actually find a lot of the answers to the questions that you had in the chat are answered in this month's newsletter on women and women's health. There's a whole article about supplements, about pelvic floor health, and many of the other topics that you were asking about. So thank you so much. Have a beautiful day, and we will see you next time.